So for my segment, we will now corner in on advanced care planning, and it will lead us to a further discussion about goals of care. And I think the real question here now is, how do we integrate all of these interventions, these communication interventions, into our pathway, for caring for our patients. Now, we must admit that our present pandemic has been the trigger for patients now expressing their need for more information. And this is just to share a statement from the Philippine Alliance of Patients Organizations when there was a review and meetings regarding ethics during this COVID time. And in this statement, the patients with severe COVID-19, they realized that stay in the ICU could be as short as just 1 week. And then there would be experiences of rapid decline, especially after these patients were intubated. So all the more there was a need, and all the more there was a need to already discuss what they would consider advanced directives or DNAR for these patients, even upon admission, and not to wait until rapid decline were to be experienced in the ICU. And there was even this in this statement emphasizing that even before admission, the information that should be relayed to patients regarding COVID and its uncertainty should already trigger discussions about advanced care planning or directives. So this is straight from the patients themselves. Now, just to share very simple definitions first for advanced care planning. Now, it's really making decisions about healthcare, and it is in the face of a medical crisis. Now, these decision making and its planning is really a process, no, and it's not just it could be more than just a one-time sit down type counseling, and the decisions that are to be made during this advanced care planning procedure should really be based on the person's values and preferences, and even discussions with loved ones. Now, the involvement of family in advanced care planning cannot be undermined. No, it's really advised that a patient or anyone of legal age, able to make decisions for themselves, should already have a say. Now, as early as in the 1970s already in the U.S., advanced care planning was already put into a motion to be legislated. And the tools were already crafted. So it's been nearly 50 years now in our more developed countries that this approach to patient care has been already made as a law. So in the US and then in the UK. So the American family physicians also recognize this, and as an ongoing process that each patient has the right to do and to have along with their care provider. And they simply defined it as, like I said, an ongoing process, and it would be translated into the action wherein a form would be filled up, and that form would contain the results of their advanced care plan, and that form would be called an advanced directive. So later on, I'll also explain that there are different types of advanced directives, but in our case now, in the phase of the pandemic, we now are seeing more disease-specific advanced directives forms that have been crafted already nationally by ethical bodies. So there is another way of just looking at what this advanced care planning is all about. Simply put, again, it's just planning for the what ifs. And we know that there are many uncertainties throughout lifespan. This whole COVID is one whole unprecedented uncertainty, and we are still learning more about it. And there are so many what ifs now for the past 2 to 3 months. And as Dr. Lin just simply put it, these can be discussed, these what ifs. So even if I am a patient, or if I'm not a patient yet, but I know that I could catch COVID-19 just by simply going to the grocery store now that our quarantine has been modified and partially lifted. So again, we need to face this reality. So what if I, a healthy female in my 50s, contract the virus? What if my immune system is not strong enough and I am rushed to the emergency room? Would I want to be intubated? What would determine my decision? What would be my chances? How strong am I to overcome the virus? So these are specific what ifs for COVID. But even before this COVID pandemic, life itself already has many what ifs. And the essence of general advanced care planning is really facing that reality, that we can already voice our preferences if we are faced with a critical decision. Whether we are sick or well right now, we have that right. And that is done and it's expressed through advanced care planning. So as I mentioned earlier, there's two main types: the general advanced care planning, and like I said, it can be made by anyone who is healthy. So in the US, it's actually a process that is encouraged by any adult 18 years and above. They are actually encouraged to make their own advanced care plan. So mas common ito sa states, no? Most of the states in the US already have documents or flyers or brochures available for most in health clinics about advanced care planning. So whether you're sick or well, you would have access to this information. And then, of course, there's what we would call a disease-specific care plan. And this would be perhaps for particular illnesses, of course, like a patient diagnosed with cancer. Maybe in the cancer center, there would already be information about how to plan forward for how you would want your care to be. Of course, there is your curative measures, which would already be part of your care plan as guided by your doctor. But as early as maybe stage 1 or stage 2, cancer patients in our more developed countries are already made to think, what if chemotherapy doesn't work? Until what point would I continue? For example, in the case of renal patients, how long would I want dialysis? At what point would I say no more dialysis? So these, again, would be specific, disease-specific ACPs. And later on, because our topic and because all of us are now facing this COVID and all of its uncertainties, nationally, we have already been seeing advanced care planning specifically for COVID-19 patients who are hospitalized. So I will share that later. Now, this third one, preferred plan of care, is usually in line with what we would call hospice patients now. It's usually designed for those who have a prognosis or are not expected to live beyond 1 year. So this is very specific now for how they wish their care to be within the life expectancy that they have now been assessed to have. So this is more specific for hospice patients, a preferred plan of care. So this all can be documented, like I said, in the form, which is an advanced directive form. So in order for the planning to be complete, no, these are the elements. No? Ito yung dapat kasama dun sa pag-uusap. And the first one, of course, is to make sure that the patient has a mental capacity. And of course, we know that there are certain principles in determining that. And if they are deemed able to make their own informed decisions, you proceed. But if not, of course, you need to have a special power or a surrogate decision maker who will be alongside them to communicate or to address, communicate in their behalf. And now, what should come after determining their capacity is giving of information. So this is where we now see the importance of the triage. No, what type of information should be given at triage? Now, it is already well made public. Know what type of pattern we could expect for severe pneumonia in COVID. If the patient does come in with signs already of moderate to severe pneumonia, the factors that could um, affect survival should already be discussed. At the same time, they should already be made aware that there may be a point that they would need invasive ventilation. So these types of life-sustaining treatments have to be explained already at the triage. Now, the information, of course, must be handled very gently. Also assessing, like Dr. Im was sharing, you need to really get the emotional temperature of the patient. We know that this is easier said than done, no? So that is why the role of our triage, or those in the admitting point, at the admitting point of care, no, should be well versed in communicating this type of information, yet being very sensitive to the individual's emotions as these are being explained. Now, another element is helping them decide. So after having given the options and saying this is our treatment plan, we also need to make them aware that this treatment plan could also change from time to time depending on their response to treatment. And you would need to also give them, um, information on what could be the next treatment escalation. So, having explained that, you would also help them decide what type of treatment they wish to have or wish not to have if they were at a point of if they are already at a critical point of illness wherein they would be prognosed to be have already distress or failure, primarily pulmonary failure if in the case of COVID. So we have to actually gently usher this topic in when we discuss and help them decide. And you have to give them, answer their questions, answer their fears. And if there are certain questions that we may not be able to directly answer, we should also be honest enough to say so, that this is uncertain, we cannot be sure. So we have to really walk alongside these patients, if not personally endorse them to the team that will continue to be communicating with them as treatment escalates, or even if as it improves. So both ways, that is the role of the healthcare team here, to walk alongside in these types of decision-making points. And of course, we want to encourage our patients to share their own values to us and, of course, to their loved ones. Okay, so what's challenging, of course, now with our COVID scenario is that loved ones cannot necessarily all be with the patient. It's usually just one family member. But then to keep those telephone lines open, we have patients, of course, who have their own phones. Some phones can have videos, so they could still communicate. And we do encourage that that continues when they are admitted. And even if they're isolated, we make sure that their lines for communication are open through technology. So they are still able to share their values with their loved ones, even if they're not physically present with them. So when would some of we would say, so doc, if they are given this opportunity to decide a triage, for example, an elderly patient with signs of moderate and potentially severe pneumonia, and then they decide that I do not want to be treated with life-sustaining, but relatively healthy, coming into your emergency room, walking and talking clearly, but then they are short of breath. And you see the sign already, and that they are categorized as moderate to severe, possibly severe pneumonia. And they tell you, Doc, I don't want any more na if ever na kailangan mag-intubate, do not anymore. And maybe they would decide already then and there. But what if in the progress of their treatment, we do see signs that they are improving with antibiotics, but they do need more aggressive respiratory support. And perhaps the doctor may deem that, oh, the heart is still strong. It could be discussed again, and life-sustaining treatment could still be considered if we do see better if there is signs of improvement, or if the attending team would say, mukhang kaya to, no, with more aggressive ventilatory support, I think the heart can sustain and overcome this infection. So the initial plan of care, or maybe the initial directive, can still change. So it's not written in stone. No, once you plan already and have a directive, doesn't mean it cannot change. But so there are times you really have to review your advanced care plans, no, with your patients and with their family. So in other cases, no, perhaps for non-COVID, some of these directives may change if you change your place of residence, or even in the perception of their quality of life. Or let's say they're in the cases of cancer, no, if there are new therapeutic options, care plans can change. You might want to try a new drug, whereas before you said, oh, no more, I don't want chemotherapy anymore. But then there are new options. So in this case, I remember also sharing my own advanced care plan, where initially I thought my final hours would be better at home. I said, okay, I think I like the idea of really spending my final hours at home. But being in the practice and seeing how families are better supported in a hospital setting, I actually changed my plan. I said, okay, I think for my family, I would rather that my final hours be spent in the hospital, but yet the goal would be best comfort measures. At least my family there would not have to worry about directly caring for me, but rather they would be there for me more for my emotional support, while the hospital team would take care of my actual bedside care. So like I said, these can change, no? And my aim now is to make sure that my family has optimum support in my final hours. So that could also happen. Now, so for advanced care planning, these recommendations would be as follows. Now, just to summarize, all critical care teams should have basic understanding of advanced care planning. No? And this is actually why we are sharing this guidance document also this evening, is for healthcare professionals, our colleagues, to embrace the importance of sitting down with patients and talking to them about their preferences and values. And the importance, like Dr. M shared, regarding decision making, that we should give them opportunity to express what they would want. Give them opportunity first, of course, to understand what the options are, and at the same time decide along with them. And if they cannot decide for themselves, to be there to give them recommendations as medical professionals. So that's why our colleagues in the triage, in our consultants in the ICU officers, they are now, I'm seeing them now more and more, be understanding how to implement advanced care planning and directives among patients and families. And of course, for patients that lack capacity, critical care team should inquire about any possible existence of an advanced care plan. So, for example, in the private setting, we may have foreign patients that already have accomplished their own, kasi it's quite standard na in other developed countries to have your either living will, no, or your own advanced directive already prepared, no, and even notarized. So for foreign patients, for patients who have been perhaps diagnosed with a chronic illness, na baka naman napag-usapan na rin nila to at na-document, our responsibility as healthcare providers should be to ask if meron, no, baka they have already expressed that. There's actually it's also said that you can have a verbal directive, no, as long as there's a witness in some countries, but ideally it should be documented. So the pandemic situation, of course, we've seen this, that it is a serious but acute illness, and it should be given priority now to introduce advanced care planning to our more fragile, especially our more fragile patients in the community or citizens in the community. Although this planning is noted to be, should be very individualized and not just sent out to the community, like saying, lahat dapat na more than 60 years old or 80 years old, dapat mag-advanced care plan na kayo. No? It should not be presented like that. It should be very individualized, recognizing the individual's right to express their preferences, whatever age they may be. And if they are not prepared to share, it's okay. What's important is the healthcare system gives them opportunity and access to advanced care planning through healthcare systems, no, and hospitals. So the process of advanced care planning, sometimes the attending team will not be prepared to really sit down. So this is the time where palliative care providers who may have been trained in advanced care planning, counseling, or even bioethics consultation teams could be called upon. So I know, of course, we only have a few hospitals in our country that have palliative care programs. We are still growing, and we are still hoping to enable all our government hospitals to have palliative care, which would help. But in the absence of that, you could either refer to bioethics consultation team if the attending team themselves cannot sit down with the patient to go through what we would call advanced care planning. So we were asked earlier, I noted that there was a question about at what point or what is the best time for this shared decision making. So we were able to come up with this algorithm. So in the attempt to demonstrate how shared decision making, advanced care planning can come into the picture. Now, this is taking off from algorithms of our colleagues in PCMAID, PCP, wherein we initially would have to categorize our patients as being moderate to or severe risk pneumonia or mild. But in both directions, whether you're admitted or not, as you can see, let's go to the arrow for those with moderate or severe risk. Once you're admitted and you are a patient who is capable of decision making, the recommendation here is the attending team facilitates shared decision making. If the patient is not capable, with the substitute decision maker. Now, once shared decision making, meaning sharing the possible treatment plan, also the possible complications of the pneumonia. And once this shared decision goes to the point of they are asked to consent, of course, for their treatment, for the medications, which now we know are some are off-label, it furthers on into giving them scenarios just in case treatment needs to be escalated. Would they want ICU care? Would they want life-sustaining measures or invasive ventilation if it is needed at some point? So this communication is facilitated early on. And if the patient would still desire full life-sustaining treatment, again, the goals of care, as I will share later, should also again be discussed, no? And that would lead them to the point of checking if advanced care planning is now appropriate at this point for the patient. Now, if advanced care planning can now be discussed, you sense that the emotional temperature, the patient is ready to talk about their decisions about life-sustaining measures. If the patient, if the team can refer to a supportive and palliative care program or service in the hospital if it's available, that can be done already, so that advanced care planning can again be well discussed with the patient. But if there is no service, supportive or palliative care service in that hospital, the attending team themselves should facilitate advanced care planning and continue caring for this patient through the palliative care approach, meaning focusing on best symptom control and, like Dr. Rojim said, psychosocial and spiritual support for the patient and for the family. So just a footnote, like I said, why Doctora, why do you have to ask if it's appropriate or not? Dapat diba, sa lahat. Again, it has to be individualized. You have to determine if at this point the patient is ready, especially when you're faced with a very symptomatic pneumonia. There's a lot of emotional stress already. Are they willing to walk through what this decision making? And if they are, that's when you can initiate that if it is appropriate. So, of course, though, we know that it's particularly important for those who are elderly and frail and have other serious comorbidities. Okay, but like I said, I emphasize that it is made on an individual basis according to need. This is just to validate that statement about it being an individual, made on an individual basis according to need. This joint statement was made by the British Medical Association, their Care Provider Alliance, because, like I said, there were general statements that all elderly should have advanced care plan, when in fact it really should be made on an individual basis according to need. So we cannot emphasize that enough. Okay, so going to the actual form. This is the form that will document what was discussed in the advanced care plan. So basically, these would be the elements. Of course, they're the situation of the patient, and then the medical interventions that they wish that should not be administered, and medical treatments that should be considered. So these would be listed down in the form, or if the form is already formatted, for them to either tick, or I'll show you the example of this form later on. And now there would be consent. In some forms, they would give you the opportunity to say if you would like to participate in research or not. And then, of course, the consent or non-consent regarding resuscitative measures. And then in the particular form I will share, there's also instructions for palliative care that the patient can be oriented or primed about and given the opportunity to indicate that they would want palliative care. So I was mentioning that there is already advanced directive form crafted, that it was included in these ethics guidelines. So you can actually go to this link for the full ethics guidelines on COVID-19 that was prepared by the UP study group. And the annexes would provide you an actual form for advanced directives specific for COVID-19. So these are actually both in English and Tagalog already. So you can access the form in this document that's made available already to us. But we were given opportunity as a society and as palliative and hospice community to review this form, and we were able to and allowed to integrate palliative care principles and the palliative care option into this form. So this is the version wherein palliative care is included. So I won't walk through each of these slides. I'll just quickly run through them to show you the elements of this available form, which is in our guidance document. So this is specific for COVID-19 hospitalization. So again, an advanced directive template for patients admitted for COVID. And basically, it states the awareness of the situation. So of course, the admitting officer or doctor would have to explain. And the element of stating who their substitute health-related substitute decision maker is part of that form. And then the main part one would go through the different treatments that they wish or do not wish to have done if they were to show signs of rapid deterioration. So these interventions would include invasive ventilation. So they are given that opportunity to decide that if they would allow or not. And then even vasopressor support, inotropic support, if they would allow or not. So take note, these are presented to them after the treatment plan has been laid out and the prognosis has also been discussed, and the chances for recovery have also been discussed with them, complications explained. So they are walked through this The idea is to walk them through these decisions. If they still wish to have CPR, if they do reach this point wherein life-sustaining measures are required, and even dialysis. So we do know that many COVID patients do go into cytokine storm and may require dialysis. So they are also given the opportunity to decide if they wish or do not wish for dialysis or blood transfusion. Part 2 corners in about life-prolonging interventions, and they are asked to tick one of these if they wish to continue all life-prolonging interventions, or if they wish to discontinue it if it has been started, or for some patients, hindi talaga they cannot decide for themselves, so they would rather have their doctor and another healthcare provider decide for them. So either one, either of the three should be discussed, and decided on by the patient. And lastly, in this form particularly, is the option for palliative care, that they know that if life-sustaining interventions also will not already be in as a decision, they would not wish for life-sustaining, they still have the option, and stated clearly here, that they would want care in the form of palliative care, meaning comfort from distressful symptoms, and including psychosocial and spiritual care for them and their family. So this form basically allows them to express that as well. Okay, so what's interesting is this is a form that also needs to be experienced, and piloted, and some of our palliative care specialists have actually tried going through this form with some of their patients. And I just wanted to share this quote kasi kahapon lang din to na-share sa akin, because when I was sharing about advanced care planning, it is not going to come across to patients the same. Some get it right away, some may not. And sometimes you really need to make it simpler. So in this particular case, ang pasyente ni Dr. Pedro, who is a palliative specialist, was asking, Doc, hindi ko to maintindihan. So what Dr. Pedro simply did was, dinaan ko sa kwento. I'm quoting from how she relayed this to me. Dinaan ni Dr. Pedro sa kwento, not directly asking from the paper, but hypothetical questions na like she did. She said, paano kung mamaya mas hirap ka huminga? Anong naisip mo gawin? So even though we have this form, like we said, we have to know our patients and how well they will be able to understand it. And sometimes we really have to interpret it in a more simpler way, and perhaps not by documenting it in the form themselves, but in the chart as to their reply. So that is another way to document a directive. It may not necessarily have to follow the form, but if you are able to elicit their preference in a language that is easier for them to understand, you can actually document verbatim, what they have said in the chart. So you can write what they have said to you in the chart, and it can also be witnessed. So the form is not hard and fast, and you have to really have a form, especially if hindi naman ma-absorb ng pasyente yung elements ng form na yan. So there's another way to document their directive. So going just quickly through goals of care discussion. So continually, there should be review of goals of care. Is the medication working? Goal pa ba natin to yung full recovery from this pneumonia? Mukhang oo, kaya, But let's say tomorrow, biglang the nagdidisat ulit, and then the patient is an elderly. Let's see again, is this still possible? What are the chances of recovery at this point? So we have to have these same page conversations na tinatawag. And we say if cure is no longer feasible, that may no longer be a realistic goal. What now is our goal? So the goal, of course, for palliative care is to continue best comfort measures to make sure that this patient still gets adequate psycho-spiritual care and social care. So whether it be through technology, allowing them to communicate. Sometimes in our own institution, we also have communication boards. So kahit naka-intubate or mildly sedated yung patient or naka-intubate, but they're still able to identify, and connect with figures or letters on the board. They're still able to communicate what their preferences are. So keeping in line with the patient's wishes is basically what goals of care discussion is. And it's not just, again, done once. It's done actually for more critical patients on a day-to-day basis. What we say to our families is, we're taking this one day at a time. Tingnan natin kung okay yung ating treatment today, if it's effective, no? And like we said, mandatory for any medical intervention, of course, is the medical indication. And that has to be well explained. So why are we doing this? They have to understand the patient and the family. And again, all of these discussions and decision-making should be patient-centered. And if treatment limitations should be determined, these should also be discussed honestly with our patients, so that goals would remain realistic, at the same time patient-centered. So this guidance document just gives a simple algorithm for treatment, goals, and decisions. Ang maganda lang dito in this algorithm, it shows us kung sino yung dapat magiging involved or responsible first to discuss, for example, the definition of the treatment goal. The doctor, of course, should be the one to discuss this, and the patient should give input as to their own goal. But it is alongside the team and the family. Now, when explaining the indication for a treatment, of course, the doctor should explain the indication, and the team should be there to understand. About patient information, it's the doctor, again, who should give this information to the treatment. And when we're at the point of discussion of patient consent, the patient should really be involved, expressing their content for this, their consent for a treatment, and the team alongside. And of course, at point of interventions, the team is responsible is the physician and patient, along with the team and the family as part of this process. And take note here, in the evaluation of treatment, the patient is still partly responsible alongside with the physician. So the physician would have to ask the patient, so how are you feeling, no? Maganda bang effect ng gamot, hiyang ba sa'yo? So not only do we assess clinically, but we also ask the patient how they are receiving the treatment, and understanding how its effect on them. So it's a cycle wherein these goals are examined, and if there are negative results, you start from the top again and say, this isn't working, so what now is our treatment goal? Okay. I think the bottom line of all this is to be brave enough. Like, this is one of our favorite quotes, that we all should be brave enough, especially as healthcare providers, to initiate these conversations that will really matter. And these patients have the right to have these conversations with us. I know we are in the forefront of a war right now with COVID, and sometimes we say, wala nang time makipag-usap ng ganito kahaba. But mind you, that's why we have to work as a team. Now, if you in the front line are in charge of rapid intervention, there should be someone alongside you in charge of decision-making and working with the patient and family and talking with them. So it has to be done as a team. These conversations cannot be done by one person alone. It has to be brought to the forefront in patient care by a team. Well, just to share, if you'd like to connect further with us, we did start a Facebook group, and this is open. We are opening an invitation for you to join. And this basically will connect us as healthcare providers along with our specialists who can answer more questions regarding the provision of palliative care. So you may look up, and if you want to join this Facebook group under Palliative Collab. And tonight we will also be announcing that the website for Collab is also open out to the public. And this particular website is really aimed in establishing compassionate communities alongside our palliative care providers and other stakeholders. So this is also the site where these guidance documents will be uploaded. And like we said, and Dr. Esther said, these are living documents. No, so as revisions come, the more recent version of these guidance documents will be uploaded to this website. At the same time, there are other references in this website for those who are really into providing palliative care. And this website will not only give you guidance, but also inspiration, hopefully, to continue working alongside us to build up compassionate communities. So this would end that's my segment. Thank you, Dr.